You know, you get stressed out working in cancer services. I've been at this for a long time. I was really, about 5 years ago, leaving the health plan and going to work in oncology and seeing the patients pass sometimes. And I take that very personally. It's hard not to take it personally when you touched on these patients. And I manage all the quality. So whenever the patients complain about their doctors or some process, that comes to me. And I try to mitigate as much of that managing risk across the state. I thought, you know what, there's a lot happening. I'm sucking my thumb under my desk way too much. I need to go talk to a therapist. I went to go see my friend Georgine Felicia. She's amazing, LPCC here in town. And she's all, Mr. Sanchez, because I used to manage her contract when I was at the health plan. We got to know her, and she knew about that shit crazy. And so she said to me, sit down here, young man. She's all, you can either get stoned or you can do yoga. I was like, what? She was like, no, seriously. She was like, you need to chill out. She was like, you can, so I was like, well, I can't get stoned because that's illegal, but I can do yoga. So I went to start practicing yoga, and then there was an aerial studio downtown, Michelle Sandoval ran. And it literally is like a hammock made out of neoprene and silk, and you do shavasana in there and a bunch of other things, but it helps you through your yoga practice. And then, and because I am the way I am in my personality, of course, a year later, I went to go get my certification in New York City. I opened up a small studio of aerial yoga. I make hammocks there in Chapman Ballroom. My husband owns that ballroom studio, teaches ballroom there. And I've been teaching now for 4 years. The practice of yoga, vinyasa, and aerial have helped me. Can you imagine me without that? You've been listening to me for the last 45 minutes. I'm like tapped in, right? Working at that level, but that's kind of what happened. And I'm so glad to have yoga in my life as a practice.
So what is aerial yoga?
It's just an apparatus that we use to help people get through their yoga poses.
Oh, okay.
And then when they get all wrapped up in it, I leave them there for about a day. They never make that move.
Get their attention.
Namaste, everyone. Do you have any questions?
Yeah. Back to the yoga. You're hanging.
How many engineers in the yoga? There we go. So what happens is I have 2 eye bolts tapped into the studs in the roof. Obviously, each of them was weighted for about 1,500 pounds. And so that the hammock is used for different aerial poses like Baddha Konasana and Shavasana. It's just those peripheral poses where you are learning about your breathing techniques, letting it go, gotta let it go, right? And calling on all the good stuff like love, compassion, kindness, and trust into your life so that you can live it and so you can teach it. And I hope you all really learn something about the cancer service today. Go ahead.
Question. I know in general, government is going towards quality care of patients. And I noticed you mentioned earlier on in the Navajo Reservation, may take about an hour, hour and a half to get there. So what kind of process do you put in place to, and I know a lot of times there's an issue of patients coming back because they may not have a ride or foot road may be flooded or whatever. So what kind of process do they have in place, given that you're evaluated by the quality care of the patients and the patient never returning? What do you do to get them to be seen again?
We make an initial connection, obviously. We talk, this is interesting that you bring this up because it was in my notes, which I didn't use by the way. But it was in my notes. But the reason that that's a great thing to bring up is because you can't work with someone who's from another way of living, connect with them in a way that they do not understand. So Western medicine to a lot of traditional Navajo people, and some that are not traditionalists, but have families that are family members that are traditionalists, and you have to be careful about what comes out of your mouth. For you and I think we're all learning, right? Every word has a vibration, and that vibration you can put on people, good or bad, right? Hate has a awful connotation. Joy has a different connotation, right? I mean, that's just as simple as it gets. When you take away the hope from anybody by just mentioning the diagnosis of cancer in some cultures, they have to spend hundreds of dollars and go back to their traditional medicine man to wipe themselves clean of what you took away from them. And we have to teach our doctors that are coming from Cambridge and Harvard how to relate to these people out there in this communities. It's as simple as that. And that's just one example of the number of things that we have to do out there. But we're lucky to do it.
Then obviously we need more Native American and minority races medical doctors.
We are, and I was really lucky enough to go to an AAIP Indian Physicians. It was in Santa Fe. It was about 6 months ago. And some of the most brilliant Western-trained traditional practitioners I've ever met. I think I was emotional the entire 3 days that I was there. These guys are spot on. It's like about what you grow, how you grow it, how you spend time with your family, how much time you need to be spending with your family and not out in the world, how much kindness is coming out of your mouth to your very own children, your family members, and how that works in to the medicine that they're trying to practice with what they've been trained in the Western part of their medicine training. It's brilliant to watch. And we see it moving in that direction all the time. And it's really exciting. Anybody else? Go ahead.
Well, one of the things you mentioned earlier too is that how clinics can lose money because it's based on the volume, and then so I know that has something to do with the turnover rate of the patients, and insurance only pays for doctors to spend so much time with the patients, and you were saying how you spend a lot of time with them. So wouldn't that kind of counteract the idea of increased volumes?
Let's talk about that out in the Gallup Clinic. So it does a little bit. I negotiated a decent contract with Indian Medical Health. It was a 5-year RFP that I had to apply for. And I learned a lot. It's part of the grant writing process that I really knew nothing about, but I learned more every day. Our physicians know that by and large, a lot of the patients aren't going to make it timely to their appointments. After they get to know the physician a little bit and they build that mutual respect with the doctors and with the mid-levels, they start to come into their appointment times more and more timely. And if we can house them, which we often do through the foundation, and we can give them gas cards through the foundation and make sure that that's not another challenge, then we work it that way so that we can get them to their appointments on time with the doctors. There's a lot of things. It's a lot of intervention, but it has to be done. Did I answer your question? As far as the money part of it is, listen, you gotta take when you're out in those rural clinics, you kind of have to take that hat off somewhat. Because it's Medicare, it's Medicaid, and it's just a couple payers out of Gallup. Like a lot of places in New Mexico. And so you have to change your focus. Now, does that mean that I'm going to negotiate the best rates I can with the payers that I have here in the state of New Mexico that are in the urban areas of the state? You bet your bottom dollar I am. I was the one on the other side of the table negotiating those contracts for a long time. I know exactly how to negotiate with these physicians, and I use that expertise all the time on their behalf. And I train other people to do it. Go ahead.
Well, regarding all these metrics, you get so many, independence, the innovation, and so on. So you measure all these things. You measure those. Do you measure things like, I'll call it, maybe you're wrong word, recidivism, patient
When they come
cured of cancer,
and then they
have
come
to come back for retreatment because you didn't give it all.
we do measure that, and a lot of that information, just so you know, is out there on the National Cancer Institute website, and also with the American Cancer Society. They keep track of all that. And we report all of our tumor registry data to University of New Mexico, and then all of us across the state, including New Mexico Cancer Center and every other oncology practice across the state, is under one umbrella with clinical research. And that is the Alliance, and it's all managed through the university. They're like a business within the university, and they are nonprofit. And so there is a lot of reporting that goes on. You know who one of my favorite guys is? He's the data guy. And why his name just left me just now, because I've been working with him for years, Chuck Wiggins at the University of New Mexico. He's our data registry guy. The man, you want to see something telling, and you need to go outside and run before you do it. Because you're going to go out there, you're going to look across the state of New Mexico to see where the cancer incidences are increasing. Breast up north, colorectal cancer up north. And those are the things you have, if you're interested in all the information's out there. It's a little sobering, but go take a look. We can do all the preventative medicine that we want. It's impacting some populations and some